let's get started. I think everybody has a pretty good sense, at least what's happening broadly in the province. We, of course, seeing cases really going very high in the province. We are now past the peak of the second wave provincially. In Niagara, we're not quite as far out, but we're definitely very close to that second wave peak. And it's, I think, almost a foregone conclusion that we'll be exceeding that in the next day or two. And this is data put out by the Ontario Science Table on Friday, which some of you may have seen, which really shows that in most parts of the province, between this yellow line and this blue line, which is about a 2-week difference, you're seeing really big increases in COVID cases. In most places, it seems 30 to 50% increase in almost all regions. So this is definitely something that's happening really across the province. I'm just going to quickly touch on some of what the provincial modeling is showing. And first off, I just want to quickly revisit, this is the modeling that was put out on April 1st by the Science Table. And at the time, you have your second wave peak here. It was showing what would be the possible trajectory going forward. If we only did vaccination without having any more intense measures, we're of course going to follow this red line. We are at around a little over 4,000 cases, so we seem to be about trending a little bit above that line. But that was sort of the scenario they were painting at that time. We've known throughout this pandemic that whenever you act early, you stave off more pain later down the road. When you delay action, things become much more difficult. And the Science Table was advising that if a stay-at-home order was put in place around this time, there's an opportunity to see the peak of cases basically around where we are now, maybe just a little earlier, and we could perhaps have brought cases back under some level of control. What their new modeling coming out on Friday is it looks something like this, where we're now actually dealing with a much higher scale of scenarios we might be dealing with. That's that second wave peak here. It's showing that if we did nothing but really vaccination, we would hit 30,000 cases. By having this, stronger measures in place, we can limit that to 18,000 cases. What we're really looking at here is by both extending the stay-at-home order to 6 weeks rather than 4 weeks, we move off this solid line trajectory into the dotted line trajectory. And by strengthening the measures as the province at least tried to do on Friday, we will perhaps move on to this green trajectory from the yellow trajectory. But as you can see, this peak is now much higher than last time. This red box is showing what they had shown on April 1st. That was the range of that previous graph I showed. So now we're dealing with a much higher potential peak. And then as you can see here, even as a 6-week stay-at-home order brings cases under control, this kind of comes to 2,000 to 3,000 cases. We're still increasing cases through June. So we remain at a state where we're going to have very high cases, really perhaps through the summer based on this trajectory with only a 6-week stay-at-home order. And of course, if the province had gone with a 4-week one, it would have been higher. They've tried to put us on a trajectory where we're here, but as you can see, we're no longer anymore on a trajectory where we actually get cases really low unless something additional gets done. And I'll come back to that in a moment. And this was a summary slide that the Science Table put out, and I just want to focus on this last bullet where it's talked about without stronger system level measures, immediate support for essential workers, which hasn't been done, and support for high-risk communities, high cases will persist through the summer. And I think that's really what we are now looking at, is a potential that we might be seeing high cases throughout the summer. And what are we able to do to perhaps salvage the summer and at least get some relief over that summertime period? Obviously, the reason we care about cases is because a fraction of cases will go on to having severe illness and be hospitalized. A fraction of those will be very severely ill and need ICU care. And right now, with cases so high, we are seeing, particularly in the GTA, that hospitals are being overwhelmed. And so this is what the hospitalization curve is looking like in the province. And you can see that hospitalizations are well past the second wave peak at this point and continuing on a pretty steep trajectory. Hospitalizations will continue to go up past the peak of cases probably for another week or two. So we are perhaps looking at a few more weeks of this continuing to go up, which is, I think, what is really worrying the healthcare sector. And then ICU occupancy, very similarly, it's already well past the peak of that second wave. And it likewise is going to continue to go up for a few more weeks until after, a week or two of cases coming under control and flattening out. The science table did present their modeling of what is going to happen to ICU admissions. And as you can see here, it basically goes off the chart by mid-April. We're, are over 700 cases in the ICU as of today. So this is, modeling so far is tracking where we would expect. And this tiny inset graph is showing that ICU admissions basically start to flatten out in sort of the second week of May at around 1,500 admissions. That's significant. The province had previously specified 150 people in ICU from COVID-19 was their danger threshold. So we're now looking at 1,500, so about 10 times above that. There's been some discussion on the internet I've seen about people saying that they're not sure that there could be that many ICU beds in the Ontario system, that once we get to 800 or 900 admissions, we might actually be topping out. I don't know how accurate that is, that these aren't necessarily reliable sources we're seeing that are official, but that does make me worry a little bit that this could actually still be a point where we could be in some real danger going forward. I just want to take a moment to reflect on what we saw in the United Kingdom, because I think this may have some lessons for us going forward. So this is what the UK's case curve looked like. They had a first wave, of course, back last year around this time. And then in October, they were seeing cases start to go up. And in early October, they went into a 1-month lockdown until about early November. And as you can see, cases had continued to go up by the time they're exiting. Sorry, it was not early October, it was late October that they went into lockdown. They were bringing cases down by late November, but as you can see, they were still pretty high at that stage. They decided nonetheless to stick to their predetermined timeline of 4 weeks of lockdown and reopen. At that point, they were starting to see the B.1.1.7 variant really taking hold in the United Kingdom. And that basically meant that as soon as they lifted measures, things boomeranged. They started to see cases go very quickly up. And they actually re-entered a lockdown in mid-December and basically stayed in that lockdown until last week. April 12th was the point which they opened. They had a small reopening in March where particularly schools were able to reopen, but most businesses were only able to open starting last week. And you can see what they learned is that having an arbitrary 4-week timeline on the lockdown, reopening when cases are high, was a mistake, and it led to basically a massive resurgence of cases. And so this time they stayed in lockdown from mid-December basically till mid-April. So a 4-month lockdown, and that's what they needed to bring cases down to a low level. During that time, of course, they've been one of the world leaders in vaccinations. So they've got a lot of vaccines out there. And so they're now hoping that with cases low and lots of vaccine out there, they're going to hopefully be able to keep things under control going forward now. I think the lesson for us here in Ontario is that we probably should be learning that same lesson. We had the experience of seeing the reopening after 4 weeks in November by the UK and what that led to. Unfortunately, we nonetheless reopened very quickly in February. Hopefully we'll learn that lesson and extend our stay-at-home order past just the 6 weeks, because I think it's probably going to need to be longer than that to bring cases to a low enough point to get to a point where vaccines are high enough that we'll be able to safely reopen. Just want to show you that, of course, cases are going to reflect in what we see with hospitalizations and with deaths. So just shifting here over to look at what deaths are, you can see that that pattern there basically mirrors what they saw in the UK with cases. Of course, as they brought cases very low, they've been able to also bring deaths to very low as well. And then, just going back to this modeling, if we're looking at this trajectory, if we end with a stay-at-home order in mid-May, and we are seeing 2,000-3,000 cases and a trajectory going up, I think the lesson is that we probably need to extend this stay-at-home order so we stay on this downward trajectory till we're at a lower point, perhaps sometime in late June, before we start to reopen. So we can at least reopen in a way where we actually get to see some relief from all the COVID restrictions. We're not just doing a partial reopening at that point. We can actually fully reopen and have the benefit of more vaccine to actually keep us safe at that point. I know the Prime Minister was saying end of last week, he hopes that by the end of June, there's a possibility that every Canadian who wants a vaccine will be able to get a vaccine. So that timeline starts to make a lot of sense, that we could actually have most of the population having had 1 dose of vaccine we could have brought cases down to a safe level, and we'll actually be able to reopen with a couple months of summer that we can actually properly enjoy. Just want to quickly show you here, going back to the UK cases, that the one good thing we have is that we aren't actually as bad as what the UK was. If we draw in what the Ontario curve for cases looks like here, we're at this stage. We're actually a lot lower than the UK was. We haven't, of course, peaked, but we are basically instituting our lockdown earlier than the UK instituted theirs in mid-December. So there's a hope that we actually don't see a peak nearly as high as they do. And so we won't necessarily need as long in a lockdown as they did. We won't need a full 4 months. Perhaps we can do it with less time than them. And just want to show quickly the hospitalization curve for the UK and then what that looks like here in Ontario. Again, you can see that we haven't actually reached the kind of level of hospitalizations they have. And the lesson there, I think, is twofold. That one, there's a much higher that this could go, as the modeling also shows, but also that we haven't gotten to quite the same danger point the UK has. And so there's perhaps the opportunity that we don't need to go for a full 4-month lockdown the way they did to actually bring cases under control. However, to get cases under control, the key thing is that we need this lockdown to actually stop people from socially interacting with others. We need people to actually really be staying home, limiting their time out and about with others. If they're out and about, they should really only be with their own households. And unfortunately, when we look at our mobility data, thus far, we haven't really seen that kind of reaction with this latest lockdown. This is people out and about doing shopping and recreation. You can see where we were last year when we were in our initial lockdown and how low that came. Didn't quite get as low through the shutdown in December, January, and early February, but we did pretty well. But so far, we're only maybe halfway there with this most recent lockdown. Hopefully this line is still coming down and we'll come back down to something more similar to last year or earlier this year. But I think that is going to be the real determinant if we really get on top of cases the way the UK was able to do or not. And we need to continue to see similar announcements to last week where the province has to keep increasing measures. Similarly, if we're looking at people staying home, you can see first lockdown, lots of people were staying home. The second shutdown, it wasn't quite as high. And thus far with this most recent one, we're not seeing it quite as high again. The good news again is if the weather is getting nicer, there is opportunity for people if they stick to their household to be outside. So they don't necessarily need to be staying home, but they do need to be staying with just their households. Now, the other part of what's going to get us through this is, of course, vaccination. And as we continue to ramp up vaccination, hopefully by the time we're able to exit a lockdown, we'll have a very large proportion of the population vaccinated, which will help us keep things under control once we've brought them more under control. I think a really key part of what the province is thinking going forward is going to be this slide that the science table put up last Friday. And what this was showing that if you're taking an age-based approach to vaccination, this will be the number of cases of COVID-19 you'd avert, the gray bars here. And that's based on the idea that older people are more likely to be hospitalized, older people are more likely to die. So if you vaccinate them, that's how you're preventing hospitalizations and deaths. And so that achieves you what the gray bar shows. But what they've identified is that there are some hotspot neighborhoods, which we've talked a little bit about in the past, where which disproportionately contribute to cases, hospitalizations, and deaths. And if we enhance vaccination in those hotspots, at the expense of vaccinating some of the places that aren't hotspots, you can actually shift to preventing the cases that you see on these orange lines. And so you can see there's actually a benefit across all age groups, but even amongst the oldest age groups, you could actually prevent more cases amongst those age groups. And what they're showing here is for every 59 vaccinations, you can prevent 1 case of COVID-19 if you're just focusing on vaccinating the eldest. If you switch to vaccinating the eldest with a particular focus on those hotspots, you'll prevent 1 case of COVID-19 for every 34 shots you administer. And so I think what this is arguing is that if we're doing about 100,000 vaccinations a day, we need to shift that to the top 20% of FSAs, the 20% hotspots. And by doing that, we can actually disproportionately prevent hospitalizations, deaths, and cases of COVID-19. I think the upshot, though, for that, us in Niagara, is that we have 1 out of 114 hotspots in the province. overwhelmingly, the hotspots are going to be in Toronto, Peel, and the central GTA, which is also, of course, where they're seeing the real crisis in the hospitals right now. So I'm expecting in the next few weeks, we may see a shift of vaccines away from places like Niagara and more strongly to places like Toronto and Peel, where they have the hotspots, where they are really struggling the most with COVID-19 right now, in hopes that the vaccine will help get cases under control there, will help relieve the huge strain on their hospitals, and as a province will manage to prevent the most lives lost as a result from that. And so I do think that's something we may need to watch out with our vaccine program in the coming weeks, that it might slow down a little bit as vaccine gets reprioritized to those hotspots in the GTA. Of course, thus far, we have had lots of good news in terms of what we have been able to achieve with our vaccination program in Niagara. You know, we are now at 95% of our 80-year-olds, 80 plus age group is vaccinated. So that's that greatest risk group for vaccination. We're almost as good now with the 75 to 79 age group, where we're closing in on 92% of that age group is vaccinated. And the 70 to 74 age group, we continue to make progress with them. We're closing in on 80%, and hopefully we can get them to 90% in the next couple of weeks. You'll remember the 60 to 69 age group, we're around just over 20% a week ago, and now we're actually a third of that age group is finished being vaccinating, and hopefully we'll be able to continue moving that age group along to start to mirror the rest of these. And overall, Niagara-wide, we're over 26% of our residents have been vaccinated. The last thing I just want to talk about here is, you know, there's lots of questions by many people around when they are prioritized to be vaccinated. So this is what the province's rollout actually looks like as they put out for phase 2. You can see we have, you know, we'd start with the oldest age group over 75 and move down. Of course, we've reopened vaccination to all of these age groups. So these different groups have been basically compressed over to actually being vaccinated in April, and hopefully you'll be able to finish them off at some point in May. The other groups for vaccination early on are people who have high risk conditions, and of course, those hotspot communities. Many people who are essential workers who absolutely need to work outside of the home are often asking when their turn for vaccination is. And as the province's graphic shows, their turn is unfortunately not going to be until June. And then there'll be a bit of a phased approach where there's a first group and then a second group. And so hopefully by getting this information out, hopefully people can better understand that although they're essential workers and it's absolutely important that they get vaccinated, obviously everybody is deserving of vaccination. Our vaccination program is designed on making sure we prevent the people who are most at risk from getting sick. And that's of course the people of older ages who are at greatest risk of hospitalization and death, and people with these underlying health conditions that put them at greater risk for hospitalization and death. And so those groups, unfortunately, are going to be before essential workers. If we start moving essential workers earlier, of course, that displaces vaccine, which means some of these groups will be vaccinated later, and that's no longer a risk-based approach to vaccination. Just to clarify those, you know, high-risk health conditions, we're currently vaccinating the highest risk ones, and so that's people who have transplants, people with neurological diseases that affect their breathing, people with blood cancers, and people who have low kidney function. And then over time, we'll hopefully be able to expand to other high-risk health conditions. And for those essential workers who can't work from home, over in June, I talked about how there's 2 groups. There'll be a first group here that's going to be vaccinated, and then the second group is going to follow. And there's actually a much longer list than just what I have on this slide, but this is the initial slide the province showed that captures the basic largest groups. Obviously, in Niagara, we did make a decision to move up some of the elementary and secondary school as well as childcare workers, given that we see outbreaks in those settings, and we hope that by vaccinating those groups, we could prevent the spread of infection that's perhaps being caused by, you know, one case in a school infects multiple different people who bring it back to their household, and we see a big pattern of spread there. Obviously, schools have been closed now, so that's become less of a priority, but that's the one group of essential workers where we saw some benefit to vaccinating earlier, but the rest are in line to be vaccinated coming this June. So hopefully that's a message that will help clarify for the public when their turn for vaccination will be. And with that, I'll turn it over to questions.
Okay, thank you, Dr. Hergy. So up first this week, we have Bonnie. Just give me one second to Allow you to unmute, Bonnie. There you go.
Hi, everyone. Thank you for hosting once again. I guess my question is, Dr. Hirji, I'd like a breakdown of where all the patients are being treated. I know we have 66 in hospital. Are they all based in St. Catharines?
That's a question for you'll have to ask Niagara Health. I don't know exactly where every patient is. They would have the best information on that. I think the overwhelming majority, if not all of them, are probably in St. Catharines. That's where the hospital, Niagara Health, set up a COVID-specific ward and has staff particularly trained for dealing with that. But I can't guarantee that every single patient is there.
And when it comes to the breakdown of the vaccines in Niagara, are we still seeing Pfizer being the main vaccine coming in, and is AstraZeneca kind of, closing in on second place there?
Yeah, I'd say most vaccinations are being done with Pfizer still. I think number 2 is actually Moderna. We in public health receive Moderna, and we're using quite a bit of Moderna in our vaccination clinics. And then AstraZeneca would be the third one there, which is being used by pharmacies and primary care. If you look at the vaccination statistics on our website, you'll see the breakdown by us, by different providers every day. And you'll see that the majority of vaccines are being given by public health and Niagara Health. And we're the ones who are using Pfizer and Moderna. So those are going to be ahead of the AstraZeneca given by primary care and pharmacy.
Thanks, Bonnie. Up next, we have Paul Forsyth, and you should be able to unmute now, Paul.
Can you hear me?
Yep.
Thanks, Meredith. Hi, Dr. Hirji and all. Question number 1, Doctor, is it too soon yet to have seen any fallout from the large St. Catharines gathering? I think there's usually about a week or 2 after something like that when you start to see cases. Have we started seeing some pop up yet?
Yeah, we have not seen any pop up yet. So don't know yet. Hopefully we'll dodge a bullet there, but I can guarantee that. One concern I do have is that with this group being one that really doesn't want to take COVID-19 seriously, I do wonder if they will even get tested if they start to have symptoms of COVID-19. And if they don't get tested, we may never actually find out if there were cases.
And follow up, Paul?
Sure, and with the likelihood that vaccines could be reprioritized somewhat to the hot zones in the GTA and Peel, would that mean that in Niagara that some of our clinics might be either temporarily shut down or scaled back?
Yeah, it's hard to know exactly what this is going to mean for us here. We don't know how much vaccine the province might reprioritize to those regions. I would imagine there will still be some vaccine coming to us. It just might be a smaller amount. So that might mean we're running smaller clinics as opposed to necessarily completely shuttering our clinics. But that is me speculating. The province hasn't announced a plan to reprioritize the hotspots. They've just voiced the intention that they want to make sure there's properly supporting the hotspots with vaccination, which I'm reading between the lines to mean that probably some vaccine will get reprioritized.
Thanks, Paul. Up next, we have Steve from Cogeco. Do you have any questions, Steve?
Hi, everyone. Thanks again, Dr. Hirji. I was just wondering what impact of speeding up the process of vaccination will the local pharmacies have? Is there an accurate way to track the influence that it'll kind of help speed up vaccinations, maybe give some people some good news? Yeah,
it's hard to really model exactly what that means. Sorry, I'm just looking here to see if I included a slide that the province had. No, unfortunately, I don't have that slide that the province or the science table showed last week, but they actually had a slide showing that if we increase vaccination from 100,000 per day to 300,000 per day, it actually did bend some of those curves and actually allowed us to, even with just a 6-week stay-at-home order, be able to flatten out the curve to a way where after we reopen, we could actually see it sustained at a low level. I don't think 300,000 per day is actually anything realistic. Everything we're seeing from the province implies that we're not going to be a lot higher than 100,000 per day in terms of vaccinations, especially since some of the news last week around the Moderna vaccine being slowed down in terms of its shipment. So I don't think that's something that's actually realistically going to happen. But I think that does tell us that if you vaccinate more, there is opportunity to bring cases under control more quickly. anybody additional vaccine we're able to do is going to have some incremental benefit to that. So absolutely, if we get pharmacies, primary care able to be vaccinating more people, that's certainly going to help. I just can't quite quantify how much help that will be.
Okay,
And do you
thank
have a
you.
follow-up question?
No, I'm good. Thank you.
Okay. Up next, we have Richard Harley. 1 second to unmute you. There you go.
I don't have any questions today. Thank you, Raylo.
Okay, thanks. Up next, Ludwig.
Yes, thank you, Meredith. Hello, everyone. Dr. Hergy, we've seen some increases on the death toll in the past few days from, I think, 378 to 384 now. Could you just tell me what are you seeing there in terms of deaths? Where are they coming from? Is it long-term care residents still, or seniors in the community? And what stories are you hearing from how these individuals contracted the virus?
Yeah, what we're, I think the first part here is that when you have more cases, you're going to have a greater number of people who are severely ill, and a greater number of people are going to pass away. And so unfortunately, with cases of being in over 100 for the last couple of weeks, we're now unfortunately starting to see the hospitalizations and deaths catch up with that. And so that's, I think, the biggest reason why we've unfortunately seen some additional persons die. I'd have to take a look closely at the 6 or 7 most recent deaths to remind myself exactly what we saw with those individuals. Definitely, we are seeing deaths more so occurring in elderly residents. We've had a few occur in a retirement home outbreak, at least a couple. So those are definitely still risk areas. Fortunately, we're not seeing the really very large numbers of deaths that we were seeing back in January when we're going through the second wave. And I think that's a testament that vaccine is protecting those most vulnerable. So fortunately, they're not dying. But without a fully vaccinated public, without any vaccine really ever going to be 100% effective, we are going to see more people, unfortunately, dying from COVID-19 when cases go up. And that's exactly what we're seeing now. The one other comment I'll make is that we did see someone we reported out last week who had died in their 30s, which was the first time we reported someone that young passing away from COVID-19. We know deaths from that group are less common, but they are more common now that we have the variants really dominating. Variants are over 50% of the cases we're seeing in Niagara. They're over 75% of cases we're seeing across Ontario.
And a follow-up question, Ludwig?
Yes, thank you. And on the topic of variants, Dr. Hergy, could you speak a little bit about them from a Niagara context? We still have well over 1,000, probably more like 1,500 variant cases now caught in sequencing, but or rather screening, but only a very small number of those seems to have been sequenced and determined to be the UK mutation. So if you could talk a little bit about that in general, the variants and their prevalence in our general area, and when we might expect to see a big data dump perhaps, or update on the number of sequenced variants. Thanks.
Yeah, so on that last part, I don't think we're going to see a big data dump on variants that are sequenced. One of the casualties of cases being so high now in the province is that the variants being so prevalent amongst those cases, as I mentioned, 75% of cases or so are now variant cases, is there's no longer that kind of sequencing capacity. So the province is no longer trying to sequence every person who screens positive for a variant. Those samples are just being left as screen positives. And that's why we've not really seen that number from sequencing go up, because the province is no longer really sequencing every case that's diagnosed as a variant through screening anymore. The province has refined their screening, however, and now they're detecting a couple different targets in that screening. So they're actually able to differentiate if a variant is likely the B117 variant versus it's one of the other variants. And so on this table here, I've actually lumped together, and the province does this with their reporting, lumped together the variants that have either been confirmed through sequencing or also have almost certainly been identified as a B117 variant on screening. And as you can see, over half of our variants fall into that category there. There's 767 of the cumulative variants we've had since February. There are 36 variants, though, that based on the screening look like they're not the B117. They're one of those other two variants, the B1351, which originated in South Africa, or the P1 that's really prevalent in Brazil. And those variants are significant because not only will they spread more easily, and they are actually much more severe than the B117 variant. And they're also resistant to the vaccine. So the vaccine, while still having some effect, is not going to be as effective. And there's at least 36 of those identified on screening. There's certainly possibly more. And this is a number that has been rising relatively quickly, I think. And so I am concerned that this is a variant that is probably circulating in Niagara and starting to pick up here. As I mentioned, over 50% of our cases now are variants. So, on any day, if we're reporting 160, 170 cases, 80, 90 of those are going to turn out to be variants. Most will probably be the B117 variant, but I think we do have some of the other variants that are popping up every day now.
Thanks, Ludwig. Up next, we have CHCH. There isn't a name, it just says CHCH editors. Do you have any questions? Nope. Okay, we will move on. Up next, Gord Howard.
Hi, Dr. Hergy. I'm just wondering, we've got 25% or 26% of people with first dose vaccination now. Is there anything on the safety side, is there anything they can do that the rest of the people cannot do at this point? And are you seeing anybody with first dose vaccination still testing positive?
Yeah, so on that latter point, we have absolutely seen people who've had one dose of vaccine nonetheless become infected with COVID-19. Sometimes that's because after you get your vaccination, it takes a couple of weeks before that kicks in, so you're still vulnerable through that period. But as I mentioned, no vaccine is 100%. We've never developed any vaccine that's 100% effective. So people are still going to get COVID-19 even after vaccinated. It just means their risk of getting it is going to be much lower, and particularly their risk of getting severely ill, such that they're hospitalized or passed away. That's going to be extremely low as a result, but they can still get COVID-19 and potentially they could still pass it on to others. So, going to your first question, the recommendation at this time is that absolutely people, even if they're vaccinated, that's great. They have some protection, but that means they should still follow all of the other public health measures to make sure that they stay safe, as well as they keep everybody around themselves safe. We're at a time, of course, where COVID-19 is surging. There's a lot of risk of COVID-19 out there. So there's more risk, even if you're vaccinated, that you perhaps could get sick from COVID-19. And the only way I think we really bring COVID-19 under control is if we all actually stick together and we together take those actions around staying home, minimizing our social contacts, wearing masks, all as one big society, all setting that social norm that we're all going to do this together. And I think if we start having some groups who are vaccinated who don't follow the rules, where others people have to follow the rules, it's going to decrease the motivation of those who are unvaccinated to continue following the rules, and we're not going to have that social cohesion. So it's, I think, really important that even if you're vaccinated, that's great. It's great you made the decision to get vaccinated, but please continue to follow all of the other measures to make sure you keep everybody else safe.
And follow up, Gord?
Yeah, I wonder, if we're at 26% now, what is the percent where you think it's really going to start to make a dent in case growth in the community? And at what point would we get there?
Yeah, so, I didn't show it this week, but last week I did show the age breakdown of our cases. And we could actually already see that in that 80+ age group, cases were not rising very fast at all. And I think that's already showing the impact of the vaccination in the group that hasn't been vaccinated. This is a bit of a continuum in terms of the impact. We're already seeing some benefit from the vaccine in terms of cases not rising as quickly. It's hard to really demonstrate that when there's far more forces driving the speed of infections to go up rather than helping to tamp down the spread of infections. I don't think vaccine is going to be really what's going to get us out of this pandemic. Just going back to the slide here that the modeling table, the science table showed, where if you were just vaccinating, you would see cases really surge, and it wouldn't be until early June where you'd start to actually see cases come down. And that would be a combination of enough people would have immunity from vaccination because he'd have been done another couple months of vaccination by that point, but also enough people would have gotten sick that the illness itself would have provided some people some immunity. So, it looks like, even if you're looking at this green line here, that if you do a 4-week stay-at-home order and you reopen, cases will start to go up. If you do a 6-week stay-at-home order where you have more people vaccinated and you bring cases lower, cases go up, but at a more gradual pace. And what the province has shown is if you have more people vaccinated, you can actually get onto a trajectory where this continues to go down. That's going to take, I think, at least another 6 weeks of people being vaccinated before we're going to be at that stage. And it's going to be a combination of we both reduce cases low enough that there's fewer people around with COVID that can spread COVID, plus increase the immunity from people vaccinated. And it's going to be that combination. And that probably happens, sometime late next month, which means we're probably in the order of 40–50% of people vaccinated, but we also have cases much lower.
Okay, thanks. Up next is Penny. Should be able to unmute now, Penny.
Hi, yes, thank you. I'd just like to ask about the AstraZeneca and the fact that in Toronto, we're seeing not a great uptake at the pharmacies and presumably primary healthcare providers as well. And it seems that that was the reason for lowering the age group to 40 plus. Do you have any sense, Dr. Hergy, that that is also happening in Niagara? I mean, my sense just from talking to the pharmacies in Niagara Lake is that they are having no problem getting rid of their AstraZeneca. I wonder what you see across the region.
Yeah, this is more, again, conversations I've had with our pharmacy and primary care partners because we don't directly see exactly what their experience is. Talking to some pharmacists, what I hear is that they are running into resistance. There's people who don't want to get the AstraZeneca vaccine because of some of the news that has been going around about it. They are able to work through it with many of the clients if they're having a long conversation talking about the risks, and they are able to find enough people that they are able to still vaccinate. So I would say that they're still managed to get people vaccinated, but I wouldn't go so far as to say that it's no problem for them. I think they are running into the challenge. It's just a challenge that they've been able to work around. I think primary care, likewise, they're running into quite a bit of hesitancy, and I think they're actually having a bit more difficulty in terms of getting people to get vaccinated. Pharmacies, people would, of course, reach out and put themselves on a wait list or sign up for vaccination. So that helps with the pharmacies that there's some self-selection there. Primary care providers are actually diving into their patient list to try and call people up, especially in the 55 to 59 age group, to see if people want to be vaccinated. And I think those cold calls, which doesn't necessarily, have the signal from people having actively signed up to be vaccinated, means that they're sometimes running into the people who probably weren't actually going to reach out to get AstraZeneca vaccination. And so the primary care partners are seeing some of that resistance, definitely.
And a follow-up question, Penny?
Not really, just Dr. Hergy, the message remains the same. The first vaccine that you can get is the best vaccine. You're not wavering from that.
Definitely not wavering from that. We're, of course, seeing more cases of COVID-19. We're seeing the data on hospitalizations and deaths. And the sooner you're able to protect yourself from that, I think the better.
Thank you.
Okay, if anyone else would like to ask one more question, can you just let me know through the chat? We've gone through a full round with everyone. Okay, Bonnie, you can go up first. Just let me unmute you. There you go.
Sorry, Dr. Hergy, I just was looking for clarification. You said 36 cases of the P1 were identified where?
So what I would say is it's 36 cases of COVID-19 based on screening are either the B1351 variant or the P1 variant. So that's the screening result. It's not 100%, but it's pretty close, upwards of 95%. And it's one of those two variants we can distinguish based on the screening result.
Okay, thanks, Bonnie. And Gord, I believe you have another question. Find you. Here you go.
You're muted. Gord, you're muted.
Try again, Gord.
I was switching back and forth to my email, looking at that while I was talking. I won't do that again. We had a call from a woman. She's a non-licensed childcare provider from her home. And she said she's been unable to find out for certain where she fits in phase 2 as far as being vaccinated, people who provide that service like her.
Right, yes. So, going back to the, phase 2 guidance, actually switching over here, for the most part, people who would be vaccinated due to their occupation, they would fall under this part at the end of phase 2 in June, essential workers who cannot work from home. Obviously, we've decided that education workers, including licensed childcare workers, have been prioritized a bit earlier for vaccination because we've seen outbreaks in those settings. So if there's someone who's a licensed childcare provider, they're actually able to get vaccinated now. Unfortunately, the unlicensed ones aren't part of the group that we've prioritized earlier. So their opportunity to be vaccinated will come in June, and they'll actually be part of that group 1.
Okay, thanks everyone. Thanks for joining us this week, and we will see you all next week. In the meantime, if you have any other follow-up questions, please email me or Courtney or Carrie. Thanks.